So today we're talking about understanding depression and mood disorders. Okay. Before we get into that content specifically, just a couple of quick things about who we are as an organization. First and foremost, we're a national nonprofit organization. We were founded in 1918, which makes us 102 years old at this point. Here in New Brunswick, we were founded in 1950. So we're doing quite well here in the province as well in terms of established. As a province-wide leader and champion for mental health, we really kind of serve a few main functions. You know, folks tend to associate us with people struggling with mental health problems. However, our real primary goal is to support the mental health of all New Brunswickers and to make sure that we're all, living our best quality of lives and our best mental fitness skills, and really getting out in our communities and engaging with the services that are out there. On top of that, we try to help support navigation and access to resources when folks need those resources. And we do try to support recovery for mental illness for folks as well. Here in New Brunswick, we have 18 locations across the province, including 3 main offices in Fredericton, Moncton, and St. John. We also have the Community Education Coordinator Program, which is a program that we're pretty proud of. It's a pretty unique program. It's a partnership with the Department of Health that allows us to have staff members placed all across the province. And what that means is between program coordinators like myself in the offices and community education coordinators in the rural areas of the province, our staff cover every square inch of this province. We also have a peer support program and an employment program called Working Stronger Together, which is located in Charlotte County. And if you've got specific questions about those, maybe we'll tackle those throughout the session or at the end. All right? Okay. So let's start with some statistics, not because everybody loves statistics, but because statistics really help us frame and provide context to why we have to have these conversations and why these conversations are so important. So, almost 3 million Canadians will experience serious depression, but less than a third of those folks will seek out help. And that's something that we need to do better on, because depression is something that is treatable, is manageable, and it's something that, we need to do a better job communicating about the hope that comes with engaging with services and resources, because it really does improve quality of life for everybody involved. During their lifetime, between 5 and 12% of men and 10 to 25% of women record experiencing at least one episode of a major depressive disorder. That doesn't necessarily mean that they experienced a chronic condition that stays with them for an expanded period of time, but rather that they experienced a significant clinical episode in a short period of time. Anxiety and depression, which are obviously 2 of the more frequently discussed mental illnesses out there, account for about 79% of all psychiatric diagnostics. And when you see that type of number, I want you to keep in mind the fact that there are usually aspects of anxiety and or depression in almost all psychiatric diagnostics. It's very common that you'll see multiple diagnostic labels, and anxiety or depression will often accompany other diagnostics as well. And finally, the World Health Organization identifies depression as a leading cause of disability worldwide. In fact, it's the leading cause of disability worldwide. And it's really a major contributor to the overall, what they call burden of disease. So the impact that disease carries on us as a community, both in terms of its health impacts, its social impacts, economic impacts, you name it. Any thoughts or questions about some of those statistics that are there? Going, gone. All right. Don't feel like you can't ask a question even if I keep going. Or like you can put in the chat like question and then type your question out. That'll give you time to do that. I do really encourage interaction as much as we can in the webinars. It makes it more fun for me and hopefully more fun for all of you as well. Yeah. So when we talk about depression and other mood disorders, it's really important to understand that mood disorders are an umbrella or a family tree of disorders. Depression being the one that tends to get sort of the most discussion in terms of branches of that family tree. But realistically, what's happening when we talk about mood disorders is disruption to the way we think, the way we feel, both emotionally and physically, and the way we behave. A big factor in terms of diagnostics often involves the idea that the symptoms that the person experiences make it incredibly difficult for them to maintain activities of daily living. And it really is a very different experience than some of the shifts in mood that we all experience from time to time. It's very normal for us to have shifts in mood that are reactions to specific events or circumstances, but those moods aren't something that persists. Usually the intensity is quite different. And most folks do have a little bit of a regulatory function where with time and in routine and all those good things, we do tend to kind of reorient ourselves to our quote unquote normal. For folks with clinical disorders, oftentimes that's not the case without some supports. So as I mentioned, mood disorders is a family tree of disorders. And there are a number of disorders under that term. The one that gets the most discussion tends to be depression. It is quite common to have discussions about that these days, which is great. We know it's a mental illness that affects a person's mood, but it's more than just a bad day or feeling a bit down. This is something that has longer in duration, stronger intensity, and the frequency are all issues that come up, as well as the fact that it's getting in the way of the ability to cope on a day-to-day level, and the fact that oftentimes without some support or treatment, symptoms will kind of stick around and they don't necessarily just self-regulate or fix themselves, right? We know that it affects the way we think about ourselves. It can affect the way we relate to others, and it can change the way we interact with the world around us as well, right? Yeah, that's a great point. Someone's just shared the fact that depression often includes physical symptoms and physiological symptoms, so bodily symptoms that don't get mentioned as much as the mood aspect. And we are going to talk a bit more about the symptoms of depression a bit later on. But ultimately, it really is something that you can't just say, oh, they just feel sad. There's major physiological changes. There's changes to our body. There's changes to our eating and sleeping patterns. There's things like unexplained pain and exhaustion. It's a very complex experience of illness. And as we get into talking about some of the symptoms and experiences, if we have time, I'm more than happy to actually share some of my own lived experience with depression as well. Really quickly, just to help people with some of the other disorders that exist under the mood disorder family tree. Bipolar disorder is another one that comes up. It involves episodes of depression, similar to what we would discuss or think about when we talk about clinical depression itself. But it also involves episodes of mania. And mania is something that involves unusually high, overstimulated mood. The person has racing thoughts, pressured speech, hyperactivity. They can completely lack sleep, and in fact, can actually push themselves to the point of complete physical exhaustion. There's a sense of unreasonable optimism or unrealistic confidence, or feeling very powerful. And unfortunately, a lot of times that leads to things like impulsive or risky behavior or decisions that really may not fit with that person's usual sense of values and ways they would choose to otherwise live their life. So it's very complex. The other thing I'll highlight is that the way each individual with bipolar disorder experiences mania and depression and the way it cycles between those things is very unique and very individual. We do know that the length and intensity of cycles for individuals will vary greatly, depending on whether they have what's described as bipolar 1 or bipolar 2. There's also things like cyclothymia, where they cycle between what's called hypomania, so not quite full not quite full mania to the extent that you would see otherwise, and a bit of depression, but not quite that full clinical depressive state. And there's even something called mixed state bipolar disorder, where individuals will experience symptoms from the depression category and symptoms from the mania category at the same time. Right? So it's a very complex and individualistic experience to try and describe. So I will say this, I haven't experienced it myself, but I do have a few friends who live with bipolar disorder. And what they tell me, at least, is that, the depression is absolutely not fun, for sure. But a lot of the, I'm going to say, consequential stuff, a lot of the damage really gets done in the mania phases. So as much as it might sound kind of like, oh, they feel great and they're happy, well, no, it's much more than that. And the consequences can be lifelong for the decisions that get made during that time frame. The other thing I want to note here is that individuals often do experience periods of wellness in between cycles of mood. And it's important to recognize that this is not a constant experience or state. And it really is something that, we need to have more discussions on and to better understand for everybody's sake. And it really, I think, is beneficial to understand how unique these experiences can be. Another branch of that mood disorder family tree is seasonal affective disorder, otherwise known as SAD. It's a type of clinical depression that occurs for most folks, and here in Canada, we tend to associate it with the winter season, though it is entirely possible that it can emerge for any season. It will repeat itself seasonally, and it involves huge changes to sleeping patterns, energy levels, mood, those sorts of things. It can be seen in women approximately 8 times more frequently than in men, though I would suggest a bit of that has to do with reporting and reaching out for help, because we can only give stats on what we know about. Other things to kind of note about seasonal affective disorder is that it usually appears for folks in their early 20s to early 30s. And it can be very tied to a number of different factors, including environmental factors, which we'll talk about a little bit later. Any questions about that? I know I saw the chat kind of moving a little bit and some questions coming up. Doing okay? Okay. The next branch or family tree branch that we talk about here. Just a sec, I'm going to pull that up. I'll answer that live. 1 sec. I'm just going to talk about peripartum depression, and then I'll come back to your question. So peripartum depression is, well, it used to be categorized as postpartum depression, and you might know it more regularly as postpartum depression. But we've kind of shifted our language towards peripartum depression because there's been a real acknowledgement that, for people who experience this, the depressive symptoms often actually start before birth, during pregnancy. And so to simply call it postpartum depression didn't fully encompass the experience of a lot of folks. So peripartum is kind of the umbrella term for depression related to childbearing and childbirth most frequently. Okay. It involves things like uncontrollable crying, feelings of sadness, difficulty feeling competent and connected to the child. It can also involve things like difficulty building bonds, which can be really challenging for both the mom and the child. We do know that for some folks, they'll have that initial period of happiness for about a month, and then symptoms will kind of start to come out if they haven't already been rearing themselves pre-birth. 15 to 20% of women will experience PPD for a significant period of time, so weeks or months. And we do know that about 1 in 7 women will experience postpartum depression, particularly. For them, they don't feel the pleasure. They're not, feeling confident about themselves as mothers. They're filled with self-doubt. They often feel a large amount of hopelessness, guilt, and shame. And sleep and appetite are often very much disrupted. This is one of those things that is treatable, much like every other mental illness, and to try and suffer through this when you're trying to adapt to life with a new child is a lot to bear, when it really isn't necessary. We can treat this, and we can effectively support parents during this time frame. So long as they're able to reach out for help and know where they can reach out for help. And we're going to talk a little bit about community resources at the end as well. All right, I'm going to come back to the question that was asked. So the question was, the number for women in a lot of these stats is significantly higher than for men. And this person's wondering what the typical explanation is for that gender disparity. That's a great question, first of all. And I don't know that we have a particularly satisfying answer that's built in concrete evidence that's been researched. I can certainly give you some of my thoughts on the matter. I do think that there is a number of factors at play. One is absolutely there is a biological difference between men and women that often in medical research and in medical circles is not appropriately acknowledged or explored. And so I do think there is a little bit of gendering that does happen. The other thing I often will bring up is, just as food for thought, is the idea that the way we express our expectations of people based on assigned gender is often harmful in a number of different ways. And one of the things that often tends to happen when we talk about the way we socialize boys versus girls in particular, is that it's much more normalized for socially and culturally in our society, unfortunately, for women to talk about feelings. And it's much less acknowledged and supported for men to have discussions around their feelings and their moods. And so oftentimes what we actually see is higher rates of mood and anxiety-based disorders in women and higher rates of addictions-based issues in men. I would argue that gender disparity or that gender difference in terms of what shows up has much more to do with how we socialize people in terms of what we tell them is an acceptable problem for them to have based on their gender than it is about the actual core root issue that a person is trying to deal with. So, I mean, those are certainly my thoughts on the matter. I'm not sure if that totally answers your question, but hopefully that helps. There was also a bit of a question around the idea that, women may experience depressions around other biological changes as well, including things like menopause. What we talked about when we talk about causation, we are going to talk a little bit about the causes of depression right here, is the idea that biological factors are at play and a piece of the puzzle in a lot of cases when it comes to mood disorder development. You know, and biological factors can be everything from puberty, child rearing and birth, menopause. Men actually go through something called andropause, right, which is they're gender comparable in terms of the shifting of hormones as they age. It can also include biological factors like, which we're going to talk about later, illness or injury. Right? So our bodies and our minds are intimately connected. You can't separate the two. And to be able to say that, you know, we can go through major biological or life changes and not have that in some way, shape, or form impact our risk, I think would be a little short-sighted. Right? But again, I want to say, you know, when we talk about what causes mood disorders, we don't have a perfect equation. You know, we don't have A plus B equals depression or A plus B equals a bipolar disorder. We don't have that. What we do have is lists of risk factors that increase the chances of an individual experiencing a mood disorder at some point in their life. Above and beyond the biological factors we've chatted about already. Genetics play a part. Right? You know, so genetics are basic heredity, right? So if my parent experiences a mood disorder, there's a higher likelihood that I will also then experience a mood disorder. And the genetic factor, the strength of the relationship in terms of genetics does vary by disorder. So it's a stronger relationship for bipolar disorder than it is for depression. But nonetheless, it's a piece of the puzzle in most times, in both cases, right? We also know that psychological factors play a part, and that can include everything from the type of thinking patterns and the resiliency you develop throughout your childhood and adolescence. You know, whether you're a positive or negative thinker, the type of self-talk you have. Can also include things like how you cope with stress, what your support networks and mechanisms look like. You know, it can also include things like psychological experiences. So if you experience various forms of trauma at different points in your time in your life, you know, there's a very strong evidence to suggest that that can play a part in the risk factors involved in whether or not you may develop a mood disorder. Environmental factors is the last thing listed on this slide. And that's not to say these are the only pieces of the puzzle, but simply these are the bigger pieces we want to talk about today. But environmental factors can be quite significant. And when I say environmental factors, I essentially am talking about anything outside your body. So the temperature of the room, you know, the type of light, the ambient noise, and those are kind of the micro factors, all the way through to really kind of the macro factors. So things like climate change is getting a ton of research in terms of its impacts on mental health right now. And we can also see things like, for example, with SAD, seasonal affective disorder, which we talked about already, incidents of seasonal affective disorder actually decrease the closer you get to the equator. Right? And that's not because it's sunny and you're drinking out of a coconut. That's because your exposure to daily sunlight hours is steadily increasing the closer you get to the equator. And we know that exposure to daily sunlight hours has a significant biological impact on our bodies, on our minds, and can be a huge contributing factor to something like seasonal affective disorder. Any other? I thought I saw another question pop up, sorry. Got those taken care of. Awesome, cool. Is there any other questions about causation? And it's okay if you want to save your questions till the end. I just like to give time and space for folks to speak up if they do have a question. Okay. So we're going to talk a little bit about some of the signs and symptoms of depression in particular, not because we don't think the other ones don't warrant discussion, but we have a limited time frame, and this is the one that we most commonly come across in society right now. So we thought we would take a second to take a look at this. And I know we had kind of had some discussion around some of the physiological symptoms previously, and we'll actually get into that a little bit here. Okay? But when we talk about some of the signs and symptoms of depression, we can kind of break it down into categories. And the emotional category is the first one people tend to think of when they think of depression. So things like feeling sad or worthless, feelings of hopelessness, guilt, shame, or anxiousness are also strongly associated with depression. For me, myself, I live with depression, and one of the things I share often is it's less for me in my personal experience. I definitely had all those feelings, but the primary dominating feeling I would describe was actually emptiness. Right? So a lot of folks will actually describe their depression emotionally as a sense of emptiness as well. It can be feelings of anger or irritability. And, to kind of tag onto that gendering discussion we were having earlier, we can sometimes see differentiation between how something like depression expresses itself in women versus in men. It's a little more frequent in men to see things like anger or irritability, rather than the sadness and the guilt you might see expressed in women. Again, I would make the argument that that's more to do with how we socialize folks based on the gender they're assigned, rather than what I would say as a true differentiation. But those are my personal feelings, and I can't provide you a study to back that up. So take that with whatever critical thought you want to. Yeah. It can also include becoming withdrawn and really kind of disconnect. So even when you are in a room surrounded by people, you feel alone and disconnected completely from the circumstances and the socialization that's occurring around you. Thoughts of suicide are a symptom of depression. And if anyone has questions on that, we can kind of address that maybe a little bit later on, but we don't get into suicide in this particular presentation. Yeah. We do also talk about the idea that there's a loss of interest or pleasure in activities that used to bring us some sense of joy. And I can't underline how intensive, at least for me personally in my experience, that loss of joy was, and still is to an extent. You truly, in situations where you should feel pleasure and joy and all those, I say should, you should feel those things. You just feel absolutely nothing. And when you feel that, it's very hard to stay engaged with those activities, and it's very hard to stay engaged with the social components that go with that a lot of times. So those are some of the emotional aspects of depression. When we talk about some of that physical or physiological stuff that was brought up earlier, there is a really marked degree of energy loss, low energy, feeling utter exhaustion very frequently. One thing that doesn't get talked about too much, but I think is important to mention, is what's called psychomotor impairments. Essentially what we're talking about with that is the idea that everything slows down. Your speed of thought slows down, your speech slows down, your movement slows down, your reaction slows down. When I talk to people about what I felt like, it was almost like dragging my feet through cold molasses just to get the most basic responses out from my brain to my mouth and out. It's not that I didn't know what I wanted to say. It's more that it was so difficult to actually get that out and expressed because everything was so slowed down. It was already mentioned earlier, but aches and pains, including things like headaches, joint pain, stomach distress, all that sort of stuff, oftentimes without other medical cause or identifiable cause. And changes to sleeping and eating patterns are really common. For some, it will swing in the direction of insomnia. For others, it will swing in the direction of hypersomnia, so sleeping way too much. In my case, I had the hyperinsomnia part, so I would sleep anywhere between 16 and 20 hours a day and still feel utterly, completely exhausted. And changes in weight often come with changes to eating patterns, particularly if this is occurring over a long period of time. So a lot of folks will experience decreases in appetite, disinterest in eating, and it can even go as far as no longer really feeling as though food has any sort of rewarding taste or value to it. So obviously, you know, if that is going on over an extended period of time, you're going to see changes to weight and body composition. But it can go in the other direction as well. Some folks will overeat. And of course, the changes in weight that come with that. Let's see the question pop up. Yeah. So someone shared that they had gone through a period of depression a number of years ago. And find it incredibly difficult cognitively to get anything done. They spent a lot of time just kind of sitting and really kind of losing time. And that's another really common cognitive issue that comes up. You know, and really it's a function of the exhaustion and of the lack of stimulation and all those sorts of things. But it's very much a real experience and one that, you know, I'll still experience to this day sometimes. So thank you for sharing that. When we talk about some of the behavioral situations that can come up with depression, I already mentioned change in appetite, but restlessness can also come up. So things like feeling a bit agitated or unsettled or uncomfortable in your own skin or jumpy. You talk about things like withdrawal from social activities, which makes sense. You know, if you think about the fact that you're exhausted and you're finding no joy in any of those things anymore, and you don't feel connected to the experience at all. Oftentimes, you know, as this kind of progresses, you will see things like neglecting self-care, neglecting the care of your environment. And there is a possibility that you will see an increase in drug or alcohol or other substance use, oftentimes just trying to kind of get through the basics of what's required of them, or to not feel the way they currently feel. And again, these are not, you know, all of the symptoms associated to depression. These are kind of just the core ones we bring up as being relatively consistent across experiences. Any other questions about symptoms? Okay, perfect. Someone else is sharing that, and that's a really good contextual comment. So they're sharing that since they've been off work due to COVID-19, given our current circumstances, as you can see, we're all working from home here at CMHA, but that this person is sharing that I do have some days like that where I'm kind of staring at stuff and not really able to accomplish much and really struggling. But that they've been taught some techniques in order to try and kind of cope with that effectively, which is super awesome. And by the way, if you feel like you want to share some of those techniques with the group, please do feel free to share those comments in the chat and make sure that it's all panelists and attendees so that everybody can see kind of the discussion that you're having. But I think that, you know, it sounds cheesy, but sharing is caring, right? And we can continue to have a group discussion about some of those coping strategies in the group chat if you choose to do that. So thank you for sharing that as well. And by the way, same. Like there are days that I think all of us find that everything is just a struggle, and that's just a part of adapting to our new reality. All right. Some of the other behavioral stuff we tend to see, or cognitive stuff we tend to see when it comes to depression, includes difficulty with making decisions, and this kind of labels it as indecisiveness. It could also be sort of a little bit of apathy or ambivalence, you know, feeling quite conflicted about things, or simply no longer feeling engaged, or like your choice would make a difference. Right? There's a big issue with trouble concentration and focus. Memory is also significantly impacted for some folks when it comes to depression. So, you know, when my symptoms really kind of came to a head, I was actually in university, and to be trying to do and keep up with 5 courses worth of reading and stuff like that was just impossible. You know, I couldn't remember what I just read. So those are very real cognitive issues. It can also kind of diminish your ability to think clearly. Like everything feels quite foggy, I guess is the best way I can describe my experience. It really just feels a little bit like you're trying to sort and swim your way through pea soup to get to a clear idea or thought sometimes. Yeah. And there can be, for some folks, a sense that something bad or ominous may happen, or it may simply just be, the sense that nothing good will happen. So that can also kind of be at play. When we talk about depression and bipolar disorder, and who it affects, mood disorders often start showing up anywhere between 15 and 30 years of age. But of course, that's kind of the guideline. It can affect anybody at any age. This is something that can show up in childhood. This is something that can show up in late adulthood. We had someone bring up biological shifts around menopause or andropause, and that's certainly another key kind of shift. We also do see a shift in older adults and seniors that often gets kind of misinterpreted as, oh, that's just the normal part of aging, when realistically, no, it isn't. And this can be effectively treated and dealt with to minimize the impacts, And when we talk about, things for childhood, it can be really hard for us as adults to put ourselves back in those shoes and recognize that children can experience this type of thing. We often kind of look at kids as like, you're eating hot dogs and watching TV and doing whatever. Like, how can you possibly? Depression seems like an adult experience, but it's certainly not limited to adults. In fact, a lot of folks who, as adults, identify as having mental illness, in hindsight, will look back and say that symptoms that they now understand are symptoms started in childhood and early adolescence. So it's not as uncommon as you might think. Right? And we do want to take a second to just kind of acknowledge that while the experience of a mood disorder definitely obviously affects the individual, it also does have impacts on family and friends and support networks. And it's important for everyone to have access to support and education and services, because the better the health of the support network, the better the health of the person. Right? It's hard to help somebody else if you're struggling yourself. That make sense? Okay. I did reference it a little bit earlier, that there's a real intimate connection between our bodies and our minds. But I did want to take a second to just take a look at some of the medical and physiological impacts and risk factors that can occur when it comes to chronic medical conditions and illnesses, and how that relationship occurs with depression. So as you can see on the slide, we've pulled some stats about various coexisting medical illnesses to kind of give you an idea of some of the occurrences. So for example, cancer, 42% of inpatients who are diagnosed with cancer will also experience clinical depression. Heart disease is between 18 and 26%, depending on the study. And if you have a cardiac event, so like a heart attack, that can jump to up to 60%. Diabetes is around a third of folks will experience a clinical depression. Dementia can have quite high rates of depression amongst it. MS, depending on the study, anywhere between 6 and 60%, which I realize is a pretty broad range, but it really does depend on the circumstances in the study. Parkinson's pretty consistently lands around the 40% mark. So 40% of folks with Parkinson's diagnostics will also experience clinical depression. We also know that strokes can lead to depression in 30 to 50% of folks who experience that. And we do see a pretty significant correlation or crossover of alcohol or drug use in individuals. And then they also experience clinical depression to go with that. That comorbidity, that coexistence of substance use or behavioral addiction and mental health concerns like depression and anxiety can be quite significant. Any questions about that, folks? No? Okay. So let's talk treatment for a minute. Okay. Treatment does exist, and depression and mood disorders are treatable. Bottom line. The treatment that is going to be effective for each individual will vary based on what the individual's needs are, what access to resources they have, their personal needs and experiences, but it is absolutely doable. Okay. Treatment can look like any number of things, including maybe your family doctor, support networks like family and friends. Schools and supportive workplaces can play a huge part in recovery for folks. We do know that clinicians are often a part of people's what we call treatment teams. So things like psychologists or psychiatrists, counselors, social workers, and peer support workers. So folks with lived experience who can then use their lived experience to help support individuals going through similar things. We also know that community education programs and support groups are incredibly important to recovery. The ability to engage with accessible and understandable education around the illnesses and around recovery and around coping strategies and wellness skills and support groups, as much as folks will sometimes hesitate at the idea of group activity. Group activity is shown to be incredibly helpful when it comes to things like mood disorders and depression. That idea that I can sit in a room of folks who share experiences similar to mine and we can figure this out together and gain skills and gain knowledge together and learn from each other is a super powerful tool. Counseling and support are included in most cases when it comes to treatment for mood disorders. CBT is one of the most popular forms of therapy that is utilized when it comes to particularly depression, but mood disorders in general. Medication can be a part of a treatment plan for some folks. We do know that, for example, when it comes to depression, there is about a third of folks with depression for whom medication simply doesn't seem to work. But medication is only one option if you look at this list of possible options that are out there, and this isn't an exhaustive list. So while medication is vital for some people in their recovery, including myself, it's not the be all end all, and there are lots of options out there. And your treatment plan has to be a holistic personal approach for you. Included in the idea of treatment and recovery is the idea of self-care. And self-care isn't just like bath bombs and like face masks, though like if you're into that, that's awesome. But what it does mean is understanding and building an awareness of your own gas tank, what puts gas back in your gas tank, what draws gas out of your gas tank, and how to manage your gas tank effectively to take care of yourself so that you can engage in the things that keep you well. Right? And when we say relapse prevention, what we're really talking about is wellness planning. Right? Not only do I need to gain and have the opportunity to explore and understand my own symptoms, my own experiences, my warning signs, what my personal experience is like, treatments that work for me, treatments that don't work for me. I also need to be able to learn about and explore options in terms of things that keep me well, keep me focused. When I'm having a tough day, what are the things that kind of keep me on track? When I'm doing well, what does that look like? And what can people do to help keep me well and keep me on that track? All of this stuff, all this work, can happen in a number of different areas, whether it be in a psychologist's office, whether it be in a community program, whether it be in a counseling session. There's lots of different ways in a doctor's office and a friend's kitchen table. When I personally, CMHA has a template for a wellness and crisis plan. And when I was filling it out, I essentially sat at a friend's dining room table and we worked through it together. It can look like anything as long as it's what fits the individual needs for that person. Does anyone have any questions about treatment and support? Okay. The next question is really around how do we support loved ones, right? Because as we said, this isn't, something that only affects the individual. It often is something that has impacts which are, I kind of look at it as a ripple effect. Like if you toss a stone into a pond. So how can we support a loved one? Well, you can offer emotional support, including just listening. And please don't ever underestimate the value of just listening. Or practical support in terms of things like, can I give you a ride to your appointment? Right? You can help them in terms of watching for signs of challenges or difficulties, because oftentimes one of the first things that happens when you're starting to experience another episode of illness is that it's almost like your insight into yourself, it gets a little bit disabled, So having people you trust that kind of know your warning signs and can help you spot them can be super helpful. And as we kind of talked about in the last slide, helping the person, if they're open and willing, because this is an individual choice, develop a plan to respond if they're headed down, a path towards illness or another episode again, and kind of knowing what that plan is and what your role is within that plan are all super helpful things that you can do. Other than that, you can do things like educate yourself about the illness, especially when we talk about things like anxiety and depression. I think folks kind of just assume they know. But my biggest suggestion to you would be to not assume and instead to ask. All right? Listen to the individual so that you understand their specific individual experiences with the illnesses, and seek out more information whenever and wherever you can. Understand that the changes you see in them in terms of their behavior or their mood are symptoms of an illness, and really have, in most cases, very little to do with you, and are much more about the experience that that person is trying to navigate through. You can ask them what you can do to help, and then listen to and respect what they say. You can offer to help with practical day-to-day tasks, particularly if they're struggling with things like their energy levels. If my gas tank has a finite amount of energy and it's going to take 50% of my gas tank to do my dishes, and then I'm done for the day, or you can pitch in today and we can go out for a walk and I'll have the energy to do that after. Maybe that can be a big help. Just my suggestion with that is always ask first and offer. Don't just assume. Acknowledge that recovery is a lifelong process and takes time. This isn't something that's going to happen overnight, and it's not something where, they're going to go get a medication and feel better, next week. That's typically not how it goes down. So understanding it's a process rather than a switch that you flip, can go a long way. And really taking time to recognize out loud for that person when you see them working towards their recovery and their plan that they have kind of been involved with and drawn up. Acknowledgement and recognition around that stuff, can play a big part in how that person feels about themselves and the work they're putting in. And ultimately, as tough as it can absolutely be, doing things like setting boundaries and seeking some support for yourself as a support person can be incredibly important. I understand it's a little bit of an overused analogy, but if you, as this person's support or one of their supports, if you don't take care of yourself, you aren't able to be there for them when they're ready to accept help from you, if that makes sense. It's the old idea of, when you're in the airplane and the masks come down, you put your mask on first so that you can then be actually helpful to the people around you, right? But really, it's a tough skill. It's difficult, but it's important to learn, and it benefits everybody involved in the end. In terms of some of and I know there's a bit of a conversation happening about support services, so we'll chat about those really quickly here. Just check my time. Okay, we're doing great. In terms of what mental services, health services are available to you in your region, it does vary by region. So first and foremost, if you're seeking out services, you need to recognize that your region probably has some specific services, and then there are also provincial services, right? Local mental health professionals can either come in the private format, which unfortunately does cost money, or you can connect through, every region has a mental health and addictions clinic. That clinic is a community-based center where all services provided by the health networks through your health card for free are provided. So you can self-refer to those clinics. So that's always an option as well. Peer support consultants are something that currently exists in all regions of the province. However, their use is pretty limited right now. At CMHA, we're really hoping and advocating for a much broader use of peer support consultants and peer support services, because there really is something to be said for someone who understands what you're going through being there alongside you. So that's something I'm hoping we'll see expand as we move along. At this point, every single region does have a mental health mobile crisis unit. Unfortunately, because they're based on regional health authority zones, every zone does have different hours of service and different phone numbers or contact methods to reach them. But all zones do have this service, and this is a team of trained social workers, mental health social workers, who can talk to you over the phone, if you're in crisis, or if you're with somebody who is in crisis. And if necessary, they can actually physically come to where you are and work with you through crisis. They're also trained to do safety assessments. So does this person need to go to the hospital, or do they not need to go to the hospital? They're trained to do that. I already referenced mental health and addiction centers, local mental health and addiction clinics. And a lot of them are making really good strides, because a lot of folks talk about the clinics and the first thing that comes up is wait times. I won't deny that wait times are a big issue here, but I just saw the question about wait times. Traditionally it's been a big issue, but I will say this: regional mental health and addictions clinics are making huge strides in terms of dealing with their wait lists. The wait time for mental health counseling at those clinics does vary by region, but I can tell you it's getting much, much better. And most clinics at this point will get you in for an intake interview, I believe within three to 5 business days. And from there, with your intake interview, you're essentially triaged, similar to the way you're triaged when you go into the emergency room with, like, let's say a broken leg. And so of course where you sit on the list will always kind of shift and move depending on who comes in and what triage level they're assessed at. But it's one of those things that, they're getting much better. I'm the program coordinator here in Fredericton, and I can tell you, when I first came to Fredericton to work out of our office here 2 years ago, a little over 2 years ago now, the wait time was in the range of about 8 to 12 months. And last time I was at a committee meeting with the director, he reported that wait times were down to about 3 to 6 months, depending obviously on triage level. With the higher end, high needs triage levels getting service, I believe he said within 10 business days. And that's the Fredericton region. Every region is different. When I worked out of the Moncton office 3-4 years ago, wait lists could be as long as 18 months. I know that has dropped significantly in the past couple of years. And I'm assuming the drop is comparable to what you would see out of the Fredericton clinic now. So I know that's maybe not a super satisfying answer, but hopefully that helps with that. With that question, let me know if it didn't. We also always recommend connecting with CHIMO. CHIMO is our 24/7 provincial bilingual hotline, and it's available to anyone and everyone. You don't have to be in crisis in order to call. In fact, I think only about 9% of their calls are crisis calls. The rest are problem solving, you know, a bit of distress in the moment, needing someone to just talk something through with, loneliness, resources. So CHIMO's a great spot if you're looking for resources in a given region. You can give them a call and say, hey, I'm looking for mental health resources in Bathurst, you know, and they'll go through their catalog of provincial resources, find Bathurst, and start letting you know about what's there. So, and they've also actually launched, I think in January, they launched a live chat function on their website. So between like 5 p.m. and midnight, I think, you can actually, instead of calling in, you can actually chat online on their website. So if you're not really a phone person, like I'm not, that's another option for access as well. Kids Help Phone is also there for folks under the age of 25, I believe. Family and friends can be a huge support. If need be, if safety is a concern, 911 is your option, and going to a local hospital for safety reasons is always there as well. And I understand that's not always fun, but having been through that process myself, I will say this: it might not be fun, but if that's where you need to be for safety reasons, that's where you need to be. And I wouldn't be here today if it wasn't for going through that process, as not fun as it was. So safety is always first, right? So I'm just reading the chat really quickly. That's a great answer, Lisa. Yeah, and if anyone wants to reach out to CMHA in your region, because like I said, we have staff in every single region. Staff in those regions are really knowledgeable about what exists in their area and how to access those things. So they can be a really great contact point to help you understand what's out there and where a good starting point might be for you and for what your needs are. Right? You can find out what staff are in your regions by visiting our website, or you can reach out to our website. That website is wrong. cmhanb.ca or info@cmhanb.ca, which is our general information. I'm going to type it in the chat for everybody. So our website again. Oh geez, look at me. There we go. Our website again is www.cmhanb.ca. You can also email the general information line at cmhanb.ca. And my email is corey.ferguson@cmhanb.ca. Yep, I definitely sent those privately. My bad. I wasn't paying attention to who my message was going to. My apologies. There we go. So this is a list of the references that we used for today's presentation, in case you were curious. All right. And unless there are any other questions, that's all I have for you today.